Hi, everyone. Thank you so much for joining us today. I'm very excited to continue our amazing series that we're calling GME Grand Rounds. So thank you for coming to our second inaugural GME Grand Rounds. We're going to have many more to come, mostly in the next academic year. So keep on the lookout for Outlook invites and emails for more to come. And if you have topics that you're interested in learning about, feel free to send them over to Amy. I'm Nishita. I'm one of the GME directors for Health Equity and Inclusion. Feel free to email it to myself or Dr. Amanda Ewing. She is our GME director of curriculum and assessment and is kind of responsible for putting this all together. But without further ado, I'm really excited about introducing our speaker today. We are going to be hearing from Dr. Kirsten Moore-Sheeley. She is a research assistant professor in the program in the history of medicine at Cedars-Sinai Medical Center, and she also holds a position as research assistant professor of history at Claremont Graduate University. Dr. Moore-Sheeley earned her PhD in the history of medicine from Johns Hopkins University, specializing in the history of global health and disease control. Additionally, she holds a certificate in global health from the Johns Hopkins Bloomberg School of Public Health. Her first book, Nothing But Nets, a biography of global health science and its objects, published by Johns Hopkins University Press in 2023, explores a fascinating history of insecticide-treated bed nets and their role in global health initiatives. Currently, Dr. Moore-Sheeley is delving into a new book project focusing on the history of vaccine research, generously supported by grants from the Rockefeller Archive Center and the Consortium for the History of Science, Technology, and Medicine. Her scholarly contributions extend to collaborative efforts on public health policy and communication, including projects with the Johns Hopkins Center for Health Security and UCLA's Luskin Center for History and Policy. Beyond her extensive research, Dr. Moore-Sheeley actively leads a working group on applied medical history. This initiative fosters interdisciplinary collaboration among historians, healthcare professionals, and scholars, applying historical insights to contemporary challenge in clinical care, medical education, health policy, and public health. Her commitment to education is reflected in her teaching, with courses addressing critical topics such as history of race in medicine, sex and gender in medicine, medical experimentation, and the broader social and cultural dimensions of disease. So without any further ado, I want to introduce Dr. Kirsten Moore-Sheeley for our talk today. Thank you.
Thank you, Dr. Jane, for that wonderful introduction. Thank you to the entire GME team here for having me. And thank you for being here. I'm really honored by the invitation to speak to you today. So how and why do people get sick? Why do some people get illnesses while others don't? And why do some people seem to get sicker than others? These questions have been fundamental to medical practice for millennia. In some cases, the answers may seem fairly simple, especially in an era with increasingly sophisticated diagnostic tests and a mass of accumulated scientific knowledge about physiology, pathology, microbiology, and genetics. Sometimes, however, the answers are not entirely straightforward and may involve multiple biological and non-biological factors. That can be a difficult conundrum for healthcare practitioners to grapple with when patients, their families, policymakers, and the wider public want to know, sometimes urgently, what is wrong and why. Historically, epidemics have been major catalysts for discussions about disease and difference. The trend continues. While studies of racial health disparities in the United States circulated long before 2020, the COVID-19 pandemic put a spotlight on such inequities, as documentation of case numbers, hospitalization rates, and death showed noticeable differences between racial and ethnic groups. Researchers tried to solve the puzzle these statistics presented through epidemiological studies, genetic studies, and sociological studies, among others. This 2021 JAMA article, written by physicians of New York's municipal hospital system, captured many experts' conclusions about the cause of these disparities, namely that low socioeconomic status and associated living and working conditions, healthcare access, health education levels, and comorbidities exacerbated COVID-19 among non-white groups. Early findings that Black and white patients hospitalized for COVID-19 actually died at similar rates when adjusted for variables such as age, insurance status, comorbidities, and site of care, emphasized for these authors that access to care played a particularly important role. Given this, they recommended a, quote, multi-pronged strategy to eliminate the persistent racial and economic disparities in health exacerbated by COVID, including expanding access to care, establishing equitable care models, for example, in health education and outreach, and to some extent, addressing the social determinants of health. These were not the only explanations and recommendations entertained during the pandemic. Some, for example, also drew attention to genetic factors influencing inflammatory response. However, those were much less likely to gain traction, at least as a primary explanation for COVID disparities. Now, again, the COVID-19 pandemic was far from the first instance in which researchers, practitioners, and policymakers in the US recognized and sought to explain racial health disparities, arguably the most commonly discussed type of health disparities in this country's history. This has occurred repeatedly with things like tuberculosis, venereal disease, diabetes, heart disease, respiratory disease, mental illness, cancer, and maternal and infant mortality, among others. Despite the long-standing nature of this issue, however, the way people have understood and sought to address racial health disparities have changed, sometimes in considerable ways. So have the reasons experts drew attention to this problem in the first place. Past attempts to identify and explain racial health disparities continue to shape the way we think about health equity today. So in today's talk, I want to take a closer look at this history and ask two main questions. One, how have explanations for racial health disparities changed over time, and how have they not? And number two, what consequences have these explanations had for addressing these inequities? The answers to these questions can not only help us understand what happened in the past, but they can also help us appreciate the evolving relationship between health, science, and society, and the ways this relationship continues to inform contemporary efforts to achieve health equity. In order to help answer these questions, I want to draw on this article by historian of public health Merlin Chao-Kuan-Yun called "What is a Racial Health Disparity?" Quote, on the surface, he writes, a racial health disparity is simple, a blunt metric of deprivation. Yet the simplicity masks contestation about its causes, ways to eliminate it, and its fundamental essence. In order to get at this underlying complexity, Chao-Kuan-Yun identifies 5 analytic traditions or experimental paradigms, if you will, that medical and scientific experts have applied to racial health disparities in the United States since the 19th century as a problem of biology, behavior, space, stress, and policy. Now, while I will be discussing each of these paradigms separately, I want to note that they are not necessarily mutually exclusive. They became popular in different periods at different times, but they were not always used as kind of without recourse to others. Sometimes health authorities drew on multiple of these explanations to explain why certain racial and ethnic groups suffered disproportionately from particular diseases, even if one was a chief factor. And Though some of these were more popular than others in earlier periods, these are all being kind of mobilized today in some fashion to help understand and explain racial health disparities. Now, as I review these 5 analytic traditions, I'll try to highlight as well some of the ways in which ideas about the cause of racial health disparities shaped proposed solutions for this issue. As Chao-Kuan-Yin reminds us, quote, baked into each interpretive prism is a set of assumptions about the mechanisms that produce disparities. A story, in other words, about where racial health disparities come from. These assumptions are and have been shaped by prevailing scientific ideas of the day, as well as social and cultural factors and the personal backgrounds of those studying racial health disparities. These assumptions also provide a framework for action. Now, before I go into reviewing these 5 analytic traditions, I want to note that while racial and ethnic categories included in studies of health disparities may seem fairly obvious or natural to us today, these categories themselves have a history. In the late 18th century, in the midst of the European Enlightenment and imperial expansion, naturalists and anthropologists defined racial categories of mankind along with their characteristics. These categories did not persist unchanged, either in their terminology, the theory behind their origins, or in the value judgments ascribed to each group. However, these categories did lay a foundation for the way people tend to separate racial categories to this day, as you can see in this 2002 article. Moreover, as we will see throughout American history, the differences that people documenting racial health disparities thought were meaningful shaped the categories they used and the ways they define these categories. Historically, most studies of racial health disparities in the US have focused on Black or African American and white populations. From the period of the slave trade onward, medical and political authorities became incredibly preoccupied with the differences between these groups, especially as the legacies of Black disenfranchisement persisted in American society. Furthermore, as immigration to the US accelerated over the 19th and 20th centuries, groups became reclassified and regrouped. So Mexicans, for example, were often categorized as white until about the mid-20th century, or the 1960s, when they were increasingly grouped with Hispanics. Some studies will distinguish between Asian ethnicities or nationalities, while some will lump all under Asian or Asian American. As has always been the case, choosing and defining categories in studies of health disparities is an interpretive act that reflects an investigator's ideas about what differences are likely to be meaningful. And these categories in turn inform analyses of findings. So with that, I do want to dive into this first paradigm, racial health disparities as a problem of biology. This idea that at the root of these disparities are some kind of innate biological structures that differ between different racial and ethnic groups. For example, genetic factors or something, as we'll see, in the nerves or bone density. So biological explanations for health disparities became popular in the 19th century in conjunction with ideas that racial groups were fundamentally biologically distinct and some biologically inferior. As I alluded to earlier, Western medical and scientific authorities had long been interested in understanding human difference, particularly between races. And there was an uptick in this interest in the US during the 19th century, particularly in the context of slavery, in which many Southern physicians worked. So Mississippi physician Samuel Cartwright, for example, claimed that Black bodies were fundamentally different from white bodies in ways that made those of African ancestry naturally suited to physical labor and to being treated like children, requiring different medical and socio-political treatment. The abolition of slavery did not do away with these kinds of explanations. Indeed, Cartwright's ideas and the ideas of his contemporaries persisted through the century and even some of them thereafter. And indeed, claims that Black people had higher pain tolerance, smaller lung capacity, and reduced mental faculties, which emerged in the 18th and 19th century, sometimes persisted in studies and treatment practices into the late 20th and 21st centuries. Now, one theory that had an incredible influence on the discourse around racial health disparities was Charles Darwin's theory of evolution, which became popular in the late 19th century. So the popularity of his work informed medical scientific claims that certain racial and ethnic groups were more, quote, primitive, quote, less developed, while others were more, quote, civilized and more developed. A group's place on this evolutionary hierarchy supposedly mapped onto their bodies. For example, with more primitive groups seen as having less sensitive nerves, and as a result being less sensitive to pain and less susceptible to so-called nervous diseases. Eugenicists such as John Harvey Kellogg, meanwhile, lamented the rise of chronic and degenerative conditions on civilized groups whose nerves were more sensitive to enervating stimuli. So one can see the primacy of biological explanations in the case of tuberculosis. Now, since the 1870s, many physicians observed that TB seemed to be increasing and to frequently manifest as an acute fatal infection among Native American and African American populations. And many theorized that this might be due to racial susceptibility derived principally from these groups' lack of exposure to industrialization and, quote, civilization, and thus their lack of inherited immunity to the tubercle bacillus. Some, such as Dr. Cyril Harris of Alabama, also implicated other biological differences, including claims about reduced lung capacity and brain size to explain rising TB rates among African Americans. Now, these explanations drew attention away from alternative theories for disproportionately high TB rates among these two groups, such as those put forth by sociologists W.E.B. Du Bois and the National Tuberculosis Association, who both blamed poor socioeconomic conditions for this trend. So privileging racial biology and explanations of differential TB rates served to naturalize this disparity, which could in turn justify inaction. Primitive groups, some claim, would simply need to go through this period in their collective development as civilized populations had, so that those who survived would build up immunity and pass that along. So we see similar thinking in the case of so-called diseases of civilization, where physicians and medical researchers claim that middle and upper class members of, quote, white races of Western Europe and North America were more prone to ailments such as heart disease, diabetes, and cancer compared to non-white, quote, primitive groups. In some cases, as with diabetes and cancer, physicians even felt that non-white groups were immune to these diseases. Diabetes, after all, was understood in the early 20th century as a disease linked to the nervous system. According to prevailing scientific theory, primitive groups' nervous system was not as developed, making them less sensitive to this pathological enervating stimuli. Cancer was also understood to be especially prevalent among middle and upper class women. Ideas that the stresses and strains of modern urban life, as well as expanded educational and political opportunities, interfered with women's reproductive roles, shone a light on the problem of cancer among white women in particular. And these kinds of assumptions contributed to the neglect of rising non-communicable disease rates among non-white groups in the first half of the 20th century, and obscured the role healthcare access and surveillance played in making such diseases visible. explanations for racial health disparities became less popular following World War II as scientists sought to distance themselves from the Nazis and their eugenics-centered genocidal project. And this effort to distance the science of human heredity from its ugly eugenic past culminated in the 1950 Statement on Race by UNESCO, a new international organization which aimed, among other things, to deploy science, and especially genetics, to fight, quote, the doctrine of the inequality of men and races. Among other things, the statement claimed that there was, quote, no scientific grounds for the hierarchy of inferior and superior races, and that, quote, some of the physical differences between human groups are due to differences in hereditary constitution, and some to differences in the environment in which they have been brought up. And indeed, in the post-war period, we see the demise of certainly many race-based biological explanations for diseases such as tuberculosis. Nonetheless, biological explanations for racial health disparities, particularly in discussions about, we see those persist, particularly in discussions about the genetic basis of disease and risk. So for instance, when researchers began to uncover disproportionately high rates of diabetes, first among Native Americans in the 50s and 60s, and then Mexican Americans in the 1980s, many quickly looked to the influence of genetic factors. In the 1960s, geneticists began to elaborate on the idea that Native Americans had a, quote, diabetic genotype, and that genetics, rather than diet, explained different manifestations of diabetes among this group compared to Europeans. Some of these ideas shaped subsequent interpretations of diabetes among Mexican Americans when researchers linked their amount of Native ancestry to high diabetes rates. Again, such explanations often diverted attention away from things like financial or geographic access to healthy food, which many Native activists have pointed to. And there are various other studies and theories proposed in the late 20th and even 21st century, pointing to a kind of a genetic biological basis for differences. For example, in the slavery hypertension thesis proposed in the 1980s. But these and other biological explanations for racial health disparities have certainly changed since the 19th and early 20th centuries, particularly in the value judgments they contain regarding racial and ethnic minorities. However, they continue to run the risk of narrowing the perceived possibilities for redressing health disparities, as well as potentially obscuring internal heterogeneity within groups. Now I want to move on to the second paradigm of behavioral explanations. So these are explanations that purport essentially that certain racial or ethnic groups commonly engage in certain behaviors or lifestyles that make them more prone to certain diseases. Explanations for racial health disparities similarly became popular in the 19th century, particularly as racial and ethnic minority groups increasingly migrated to and within the US. Very often physicians and health officials blame new immigrants or emancipated African Americans now crowding into urban areas for poor hygienic habits and their, quote, carefree attitude regarding proper hygiene. Sometimes these explanations would commingle with biological ones, for example, in the idea that primitive populations with reduced mental faculties did not understand how to maintain their health or live a life of moderation, and that their underdeveloped immunity to the plagues of modern life made them that much more susceptible to these diseases. But these explanations were not simply leveraged by those from outside the communities under discussion or under study. Academics, health authorities, and activists from within racial and ethnic minority groups also pointed to things like moral laxity as a reason that their particular group suffered disproportionately from disease. Early on, behavioral explanations were really the predominant mode of understanding venereal disease rates. Longstanding racist tropes and stereotypes of Black people as promiscuous led medical authorities to claim this group was unusually prone to syphilis and other venereal diseases in the early 20th century. Many physicians cited this group's behavior as a reason for the high prevalence of these diseases and their difficulty in treating them. Such assumptions undergirded the U.S. Public Health Service's infamous Tuskegee syphilis study, which examined the course and impact of the disease among African American men. So baked into the logic of this study was the idea that this population probably had high rates of syphilis and probably would not seek treatment for it. And assumptions about the prevalence of syphilis among African Americans also led authorities to assume that many cases of heart disease among African Americans were due to venereal venereal infections, even when a patient claimed they had no infection and when they had a negative Wassermann test. So these assumptions kind of were carried into other realms of medical care. This occurred, and again, such heavily entrenched assumptions about African American behavior diverted attention away from other factors, such as the lack of access to healthcare and explaining health disparities. And this occurred even following local public health campaigns of the 1930s, which demonstrated that access to tests and treatment could vastly reduce syphilis rates across all groups. Behavioral explanations began to shift over the course of the 20th century as experts began to observe increasing rates of chronic disease among non-white populations, previously thought to be immune, and as developments such as the Great Depression of the 1930s and the Civil Rights Movement of the 60s drew attention to the health impacts of poverty. In many cases, commentators linked race, socioeconomic conditions, and lifestyle rather than see certain behaviors as inherently characteristic of a particular racial or ethnic group. So after World War II, physicians and health officials began to sound the alarm about rising diabetes rates among non-whites, particularly poor African Americans. And many, such as Dr. Harold Dobson, worried that due to strained socioeconomic circumstances, as well as, quote, lower intelligence, this latter group struggled to cooperate in their diabetic care. Their, quote, mental and physical incapability of managing diabetes, he claimed, combined with access to nutritious food, contributed to their high rates of disease rates and mortality. And so he recognizes the kind of socioeconomic barriers, but also looking to behavioral explanations to kind of explain the rising rates of diabetes among especially poor African Americans. Now, this issue and other issues related to chronic disease were taken up in 1985. When the U.S. Department of Health and Human Services put out a landmark report on racial health disparities known as the, quote, Heckler Report, named after HHS Secretary Margaret Heckler. And it synthesized available research to study disparities for diabetes, but also stroke, cancer, infant mortality, among other things. And this report, similarly, like the Dr. Dobson I just described, recognized the role that poverty and lack of access to healthcare played in producing health disparities between white and, again, especially Black populations as the main focus. However, many of the report's recommendations focused on health education to help change lifestyle choices and behavior. Heckler emphasized these in talks she gave to publicize the report as well. The report's focus on individual responsibility rather than on government action or policy is not entirely surprising, given that it was produced under the austerity regime of Ronald Reagan. However, some critics, like President of the National Medical Association, Dr. Edith Irby Jones, pushed back on this, saying, quote, Mrs. Heckler's implication, of course, is that if Black people would only behave, their health problems would be solved. As Black Americans, we know it is not as simple as that. Blaming the patient will not cure the ills of America's underserved minorities, end quote. She instead advocated solutions that would provide access to better nutrition, housing, and jobs. So behavioral explanations have persisted in discussions about racial health disparities as well in the 21st century. In their 2010 article, Annis Kim and others analyzed American newspaper coverage of racial health disparities. finding that experts and commentators relied most heavily on behavioral explanation, whether as a singular cause of disparities or as part of a cluster of multiple causes. Behavioral explanations today are less flagrantly pathologizing than they were in the late 19th or early 20th century, and tend to be less essentializing as well. Yet, as Kim and her colleagues point out, they can still focus discussion about solutions on individuals rather than addressing broader social, economic, and structural factors that contribute to health inequities. So next, I want to move very quickly, move on to talk about spatial explanations, which essentially linked differences in location and spatial relationships to health disparities between racial and ethnic groups. So during the early 20th century, amidst rising immigration and urbanization, public health officials and researchers began to look at racial health disparities increasingly through a geographic and environmental lens as a problem of space. Much of the time they did this in discussions about the potential threat racial and ethnic minority groups pose to better off neighborhoods, particularly through the vector of germs. We can see this, for example, in the identification and creation of so-called lung blocks across major American cities in the early 20th century, as in St. Louis, depicted here. City health officials documented high rates of TB in homes and neighborhoods of minority groups and used these maps to undergird practices of redlining to try and contain disease and blight to certain quarters. These were not accompanied by efforts to improve housing or health services, and sometimes resulted in the raising of impoverished neighborhoods in the name of public health and disease control. During the civil rights era, the 1960s, researchers began to highlight the links between residential segregation and differential access to healthcare resources. In this formulation, the health of African Americans in particular suffered disproportionately because of the geographic as well as the socioeconomic inaccessibility of quality care. As head of the Chicago Regional Hospital Study, sociologist Peter Devise documented the concentration of public hospitals in one section of town, making it difficult for residents in other areas to access these institutions. He also documented the significant disparities in physician presence between neighborhoods based on what percentage of the population was Black. The 1965 uprising in Watts similarly highlighted the lack of healthcare access in South Central LA, which ultimately led to the establishment of the Martin Luther King Jr. General Hospital in 1972, publicized here. Later studies around the turn of the 20th century or 21st century expanded on this work to look at the relationship between segregation and disease and mortality rates. And while it could be difficult to understand the specific ways in which segregation contributed to higher disease and mortality rates, later researchers, such as Anna Diaz-Rue, identified issues such as the limited walkability, limited or non-availability of certain foods, concentrated advertising for harmful products, for example, cigarettes, and lack of social services as potential contributors. And so this later work highlighted the complex relationship between racial health disparities, geography, and socioeconomic factors, as it was difficult to attribute specific disparities to specific defined causes. Now, since the 1980s, some researchers have also taken an environmental justice approach to the correlation between geography, race, and health, particularly disproportionate rates of respiratory and cardiovascular illness among those living in low-income minority neighborhoods. And their work showed that these neighborhoods were more likely than others to be located near garbage dumps, factories, and other toxic environmental hazards. So Robert Bullard's 1990s book, Dumping in Dixie, was a landmark work in this line of analysis, providing case studies of poor Black communities harmed by the siting of toxic waste facilities and landfills. He also listed strategies Black communities use to cope with these environmental hazards and articulated an environmental justice model for addressing such communities' concerns. Community activists have since drawn further attention to the links between socioeconomic status, hazardous environmental exposures, and race, calling for more research on this connection and taking legal action for greater protections and compensation for victims. Now, as with the previous two paradigms I discussed, this one has shifted certainly over the past 100 years from one that flagrantly pathologized groups to one that seeks to highlight persistent inequities embedded in the country's social and physical landscape. It continues to illuminate the many interconnected non-biological factors that contribute to health disparities, though with the exception of obvious environmental hazards, can be difficult to fully quantify. Now I want to turn to the fourth paradigm, that related to differences in accumulated stress. Now, stress, specifically the stress of civilization and civilized life, had come up in the early 20th century to explain, for example, why white populations seem to suffer disproportionately from heart disease and diabetes. However, beginning in the 1970s, researchers began to take a new approach to the issue of stress. They identified and measured the physiological effects of accumulated stress due to racial discrimination. So around 1978, epidemiologist Sherman Jones introduced the term John Henryism, defined as an individual's self-perception that they can meet the demands of their environment through hard work and determination. And he and his colleagues used this concept to describe a coping strategy that Black men in particular relied on when confronting barriers produced by racial discrimination. And they then linked rates of John Henryism to rates of hypertension, which were also disproportionately high among Black men. As he and his colleagues noted, and as you might see if you read the questions on the scale, John Henryism as a concept wasn't racialized from the beginning. James thought it could be applied to anyone. Education level for him seemed to play a particularly important role in this idea or concept of John Henryism. However, as they continued to examine the impact of this coping strategy on health, they concluded that it was especially pronounced among Black Americans. In 1992, behavioral scientist and public health researcher Arlene Geronimus continued this line of analysis in proposing the weathering hypothesis. Looking at racial disparities in infant mortality, she noticed that infant mortality rates were much higher for Black populations when women had their first child in their 30s, not as teens as many kind of expected. And this contrasted with white populations who had higher rates, not only in the teenage group, but lower overall mortality rates compared to Black populations. So this observation led Geronimus to suggest that social inequalities rooted in racial discrimination had differential impacts on a population's health, and that these differences were compounded by age, making it more likely for an older Black woman to have complications in childbirth, sometimes fatal complications. Quote, socioeconomic inequality, racial discrimination, or race bias and exposures to environmental hazards, she explained, may affect differentially the health of women who will become mothers, not only in absolute terms, but also interactively with each other and increasingly as women age. Around the same time Geronimus proposed the weathering hypothesis, others were studying different aspects of the effects of stress on disease. So in 1993, neuroendocrinologist Bruce McEwen and physiological psychologist Elliot Steller coined the term, quote, allostatic load, referring to the wear and tear that stress creates on the body, leading to the acceleration of disease processes. They elaborated physiologic mechanisms through which the body succumbs to chronic stress, as well as biomarkers to help study the development of allostatic load. Although McEwen implicated things such as environmental stressors in the development of allostatic load, as you can kind of see in this diagram here. He did not link those explicitly to racial health disparities, but in the mid-2000s, researchers, including Geronimus, who I was just talking about, began to mobilize the concept of allostatic load to investigate racial health disparities. Both allostatic load and weathering are used in contemporary analyses of health disparities, particularly in reference to things like heart disease, stroke, and maternal and infant health. And these stress-based explanations for racial health disparities gained substantial traction during and after the 1990s, when concepts such as the social determinants of health also became more widely known and adopted. And the ability to use biomarkers to measure the body's physiological response to stress, for example, in studies of allostatic load, has added appeal to this paradigm. But as we've seen with the spatial paradigm, it is also more likely to suggest solutions that lie outside the confines of the clinic. I want to very quickly tackle the last of these paradigms, which is that as a problem of policy, which sees the health disparities rooted in certain public policies. Many around the mid-20th century began to comment on the role that segregation of healthcare facilities and healthcare professions in particular played on health disparities among Black and white populations. So desegregation policies and the advent of Medicare and Medicaid in the 1960s marked an inflection point that later researchers would use to examine retrospectively the impact of racial segregation on racial health disparities. In 2006, for example, economist Douglas Arnold and colleagues showed that mortality rates for Black infants declined more sharply compared to those for white infants following desegregation, and that this trend was especially pronounced in the South. More recently, in 2013, epidemiologist Nancy Krieger and colleagues found a similar decline in infant mortality rates in the wake of desegregation. For both research teams, increased access to healthcare and physicians seemed to reduce these health disparities. Of course, desegregation and the advent of Medicare and Medicaid did not entirely solve the problem of healthcare access, nor did it solve the problem of the underrepresentation of physicians of color in the profession, who historically have shed significant light on racial health disparities and their potential causes. Addressing those issues remains an ongoing challenge. Nonetheless, the history of this explanatory paradigm can provide inspiration as we move forward. At a time of great change in federal policy and funding, it would behoove those with the means to do so to document some of the health effects of these changes. To quickly conclude, when diagnosing a problem such as health disparities, one must consider multiple factors that might be at play. Over the past 200 years, health authorities have pointed to a number of possible factors, including biology, behavior, geography, environment, stress, and public policies. As science and society develop, the ways in which we think about the impact of these factors will undoubtedly change. In the early 20th century, people relied heavily on long-standing, often racist assumptions about biological difference, as well as racial stereotypes about behavior to explain health disparities. The development of genetics over the mid-20th century, which helped to challenge previous ideas about race biology, established a new language for articulating why some racial and ethnic groups suffer disproportionately from certain diseases, one that seems more politically neutral, but still risks naturalizing disparities. The civil rights movement of the 1950s and 60s shined new light on the role of racial discrimination and its relationship to poor socioeconomic conditions and healthcare access in exacerbating health disparities. The revelation that desegregation did not completely eliminate discrimination and socioeconomic inequities has appeared in more recent work on the differential health impacts of chronic stress, as well as hazardous environmental exposure. As has happened in the past, including over the past 25 years, researchers, health officials, and policymakers will come up with new theories to explain the cause of racial health disparities as scientific knowledge social and economic conditions, the landscape of healthcare, epidemiological realities, and documentation practices around race and ethnicity change. Now, history offers no easy solution to the problem of racial health disparities, though neither, I would argue, does medicine. The reasons why certain groups suffer disproportionately from poor health outcomes can be exceedingly complex and linked to a variety of factors outside the traditional domain of the healthcare professions. The ever-evolving economic realities of healthcare provision in this country also mean that providing necessary medical care will remain an elusive goal. Striving for and achieving health equity should be a multidisciplinary effort involving experts from many different domains. History and historians, I believe, can help understand how and why things change, whether health disparities themselves, their interpretations, or their proposed solutions. And in doing so, I think they can help us navigate the complexity of this important, long-standing issue and develop historically informed ideas about how best to move forward. Thank you. That's a very good question. So I just want to repeat for those online, basically what advice to give medical students today who are increasingly interested in understanding health disparities and racial health disparities in a climate that can be described as hostile to those efforts. This is something that I have thought about while creating this talk, and I don't have, again, simple solutions. I think we all need to think creatively about ways to frame, for example, research and how to pursue these kinds of questions, but do so. And I don't have specific examples, but I do think thinking creatively about how to ask these fundamental questions that maybe there's ways to get around the technical issues of language that seem to be one of the many barriers. And I think, increasingly looking to private foundations or research, people who provide funds for research might be a way to support studies in this area. In terms of and that side of it, I think being as educated as possible about the various potential factors that can be at play with any given patient, being aware of the historicity of the disparities of a particular patient's, maybe their experience or their potential knowledge, can help shape the clinical encounter. Again, I don't have super specific things, but I think keeping those in mind would be helpful. Thank you so much.